Hi, my name is Mary Gager, and I've been involved with the epilepsy for about 3 years because my granddaughter has epilepsy. In addition to Dr. Saneto, our medical plan will also include Dr. James Owens and Peggy Friel. Dr. Owens is an associate professor of neurology at the University of Washington and works in the areas of neurology and epilepsy at Children's Hospital. Mrs. Friel previously served as social worker in the Epilepsy Center, and she focuses on adults at Swedish Hospital. We also take a few questions from the audience and our webcast at this time.
My question is, does genetics play a large role in epilepsy, and have there been many studies on genetics and like twins? If one twin has epilepsy, would the other twin likely develop epilepsies? And I'm talking obviously about identical twins.
The answer to that, yes. Genetics is making a huge inroad into epilepsy. I think when we created the last next generation sequencing chip, we put on 428 different genes we thought may be responsible or modulate epilepsy. So 10 years ago, there were probably a handful. So we're making great strides in genetics. Genetics won't be the complete answer because there are so many other types of epilepsies that are caused by things like trauma and infection. But certainly what used to be called idiopathic, and I'm aging myself now, but there are lots that we still have to learn about how genetics not only can be a primary etiology, but modulate epilepsy. So yes, I mean, this, if you have epilepsy, this is the best era to live in for genetics. Now, insurance companies are starting to back off covering that, but we kind of deal with them one at a time. We have those guys in the black limousines with the black suits that speak Italian that we go visit the gatekeepers, but that hasn't been working well lately.
Actually, you might want to live in a generation after this, just because our tests, I think, are smarter than we are at this point, right? So all these fancy genetic tests tell us there may be something wrong, or there is a difference between your child and other children, but we don't really know for sure what that means, or whether that means that they'll have epilepsy. You know, so our tests sometimes are actually smarter than we are. Not a surprise.
So talking about genetics, like I say, so my son had already had. So my son has Dravet syndrome. So obviously he had the test for Dravet syndrome. Is there any other test as a genetic thing that he should have to see more in depth?
Well, I think you can always do more tests. But for instance, I take care of a family that had twins with Dravet syndrome, SCN1A gene mutation positive. And I got a freebie from the company that I know real well, and it turns out that they also have, well, now it's only he also has a mutation in another gene that gives you epilepsy. And so he unfortunately had 2 hits, and maybe that's why his epileptologist is so frustrated with trying to get him under control. But we wouldn't have known that. Now, does that happen in all cases? No. And, you know, I think it's just sometimes being lucky is better than good. And so, but unfortunately, I think that may be causing why I'm having such a difficult time. And I'm so frustrated at night when I can't control them. So that is a possibility, but, you know, genetics is such a young field, and we're just learning so much more. And like the good Dr. Owens had mentioned, the tests show us things that we can't answer. And when you read the reports of mutations that are of unknown significance, you scratch your head sometimes. And then you do a lot of hand waving, and then you kind of hem and haw, and then you say, well, I got to go, my time's up. And so there's a lot of that too.
Hi, I'm a school nurse, and I have a high school student who was on traditional medications and not having a lot of control, and so now he's taking the CBD medication at home. Mom would like for us to keep a supply in case we have to shelter in place because of some kind of natural disaster or emergency, but because we're federally funded, we're not allowed to. Do you ever see the CBD being separated from the marijuana as far as legality goes?
I think there is a bill in front of the state legislature in the state of Washington to separate the two. But, you know, I hear you, because Seattle Children's gets federal funding. And so we are very limited in what we can do with CBD. So I hear your pain.
Dr. Anderson spoke about generic drugs versus the name brand, and I was under the impression for Trileptal, if you were able to stay with the name brand. I wondered if you had thoughts on that.
I think this is a controversial point. So I'll wade in, but I'm really just on the panel for color and for fashion sense. So I'll leave it to everybody. So, and I may be in the minority here, but I think that for the most part, generic medications are fine for the vast majority of patients with epilepsy. We do recognize that there are some patients for whom it does seem to make a difference. Those patients who are really sensitive to small changes in drug level. I think the real challenge is that now there are so many manufacturers of generics, and one generic can vary a fair amount from another generic, and she probably talked about that. So if you can stick with a single generic manufacturer, which is challenging to do, it's not really up to you, so much the better. The reason that sometimes brand is preferred is partly that, because if you're sticking with brand, then you have the same supply every time. But for most patients, to be honest, it doesn't matter. And for a lot of our medications, we recognize that they are very expensive, right, if you're getting brand. And that formularies may not cover the brand name, where they really push you to be on the generic form. And that becomes a real challenge. So we have to take that into account as well. So.
Yeah, hi. I don't know if you're particularly suited to answer this question, but maybe somebody in the audience can. So it's regarding work. So I recently, I was an outside sales rep, and between having seizures and an accident, I lost my job. And in the process, I had to be kind of sneaky, because you know, you have a seizure and you can't really, maybe you attribute it to something else, and you continue to drive. So now I'm, you know, out there looking for a new job, and I'd like to not have that sneaky feeling. Yeah, I'd like to come right out front and say, you know, I have this condition, and you know, with the secrecy of the United States, it seems I'd like to be able to do that, not start it out on this, you know, sneaky foot. But I'm being told maybe you don't want to do that.
And particularly about getting the job, or particularly about the driving component of the job?
Well, I mean, through the job description, you can eliminate the driving, but something might come up. Hey, can you run out and get some donuts? No, yeah. So I don't want to be sneaky on that. Can you run out and get some donuts? No, I got a bad foot. You know, and so I don't know how to deal with that, and I don't know if anybody is able to address that.
Well, you know, there's vocational programs specifically for people with epilepsy, and it might help you to go there, like Bob Frazier at Harborview, because they've been doing it for years and years and years, and I think they could recommend jobs that for you to pursue and how to deal with that particular issue.
That's who, Bob?
Bob Frazier.
At Harborview.
Yeah. He's still at Harborview, right?
I think
Yeah.
so.
We've got some input back here as well.
Hi, my name is Marilyn, and I also have epilepsy, and I have dealt exactly with what you are experiencing at work. What I normally have done, up until about 13 years ago, I used to have complex partials. And I thought that that was just too big of a surprise to not let an employer know. And so I was up front. Every job I interviewed for, I was right up front with it. Mainly, I told them what might happen, because I knew from people telling me. And I would say to them, it doesn't affect my learning, it doesn't affect how I do the job. It only means I may need an accommodation once in a while. And I've only had one situation where it backfired on me. And the other thing that happened, like I said, I only get auras now and again. But the main thing I told people, it also affects how I learn. And short-term memory and those kind of things always add in. And I don't know if you're worried so much about how you learn more than the seizures, but I've told people, for me to learn something brand new, it's like putting a puzzle together. First I need the border, or the corners, then I need the border, and then I do the blue and the green and whatever, and then I've got the picture. And that seemed to be more helpful to someone who might be afraid of seizures than anything. And I have only had trouble once that I can imagine, other than people wanting to walk away from you because they're afraid they're going to catch it. Which is fear. But I hope that that helps you.
Yeah, it does. Thanks.
Okay, we've got more input.
Yeah, hi. I'm Bob Fraser from Neurologic.
Not an RV right now.
I'm here to tell my story. No, our vocational services program has information brochures out in front. I appreciate the plug, Peggy. But we do take new people every Tuesday at 10:30, and we figure out funding so that we can get vocational services through our program. But thanks much.
Sorry. Unrelated.
So I have two questions, not related. One of them is has to do with the medical marijuana, and how is it that it was first discovered as a potential, or the CBDs as a potential treatment? Is it by accident, or who noticed? I mean, where did this all come from? And then my other question has to do with autism. I work with in the pediatric population with kids with autism, and so when a medication is being prescribed for them when they have seizures, and you talk about the side effects of like Keppra and Topamax causing aggression, or can contribute to aggression, how much do those autistic behaviors come into play when deciding, or is it based on the EEG results?
I can answer maybe 1.5. So actually there were reports in the literature in ancient China of using hemp to control abnormal behaviors that were described that sound like epilepsy. So it's been used for quite a long time, at least anecdotally in different cultures. So its ability to control seizures is sort of serendipitous by kings and other people from China to England. The first reports were actually by the group in England, Sheridan. Mm-hmm. He described some benefits with a concoction of a cannabis plant. And the extraction seemed to help his patient, but he didn't like it, so he went off it and had seizures again. And there are incidental case reports like that. So it's been around for quite some time, but never well studied. Sort of anecdotal. I tried it and it seemed to work. Mm-hmm. Your other question has to do with autism, and there are really two sides of the fence, depending upon THC levels. And there was some early reports in California of the rage behavior that you can see in autistic kids, and how plant extracts were very helpful for that. Now you have to weigh that in with the MS data that was recently published, suggesting those teenagers who smoked marijuana when they became adults in the 80s and 90s from the 60s had a highly increased amount of psychosis. Mm-hmm. So is it the THC? Is it the CBD? It's something we don't know about yet. So it'll be interesting in some of these trials because some of the kids with Dravet's have very challenging behaviors. And it'll be interesting to see how the pure CBD, which is what the GW pharmaceutical study will be using, acts on behaviors.
And I think the other part of your question was about conventional anticonvulsants, we might call them. I do know something about marijuana, which I learned in high school, which is that toilet paper makes bad rolling paper. I'm just going to throw it out there. So I heard. So, you know, it's a great question. So for kids who have behavioral problems, we're often hesitant to use these medications which have behavioral side effects, you know, as a prominent piece. So levetiracetam would be one good example of it, Keppra. That having been said, certainly we've all seen patients who do well on it and don't have the behavioral side effects. Deciding which of the now, 29, 30 different anticonvulsants to use in a patient really involves a whole lot of different factors, including the EEGs you mentioned, including that child, what other struggles they're facing, are they having behavioral side effects, including what might be available for the patients on their formulary, what can they afford, is sometimes still having to be taken into account, at least in the United States. So, in our healthcare system. So there's a lot of things that come into play. But then again, for example, levetiracetam, although it does have the behavioral side effects, it oftentimes is very safe in other regards. So sometimes that becomes the predominant factor in choosing. I'm not sure if I answered your question. Okay. Thank you.
One quick question for you. Have you seen, or is it possible to get two different results from the same medicine but different brands of the medicine?
Different generic brands?
Yeah, correct. Different generic brands of the same medicine?
I maybe have seen that once or twice, where the pill color changed. They said the pills look different, and now Johnny's having more seizures. I've seen that a few times, and there certainly is good evidence in literature that that exists. So that can happen, which has to do with the way the generics are compared to brand as opposed to each other.
And there can be some mechanistic problems because sometimes pills change shape, and it's easier to cut a pill that's scored versus a triangle pill. And so it's a same drug, it's a different generic, but it's harder to cut. Let's say you need a quarter of a tablet, which for those pill cutters out there can be really hard. And it's triangular. Well, that's really hard to cut. And so you can get different effects subtly by that.
A question from our webcast audience. Are there any concerns about nasal, Versed, or Valium use out in the community or in schools with children of all ages and sizes?
No.
So we were sort of the drivers in the state on using intranasal midazolam. And the safety and the efficacy was pretty well vetted in Salt Lake City at a primary children's. And it seems to be very comparable with the rectal formulation of Diastat, although much more socially acceptable than malls and classrooms.
I wanted to say thank you for that, actually. I know the Epilepsy Foundation played a role in that too, and it personally has helped a lot. And I know you guys have been working on that for a long time, so thank you. Quick question related to the genetics diagnostic testing. Are there any other diagnostic tests that are available now that might be relatively new or that are coming that would help answer some of those questions? It was intriguing, the map of, I think it was mouse brains that you had that showed the different CBD1 or CB1 receptors. Are there equivalent tests that you can do on people right now that would help you diagnose whether or not certain drugs are going to be more effective or not? Or is there anything that you see coming that might do that?
Whoa. You know, we use very gross, there are things you can do with somebody who donates their brain versus somebody who wants to keep their brain and keep going. So the rat in that study gave up, unfortunately, his life to get that slice done. it would be nice to be able to do things like that in humans, but so far volunteers have been really limited. We do have better neuroimaging methods, and I know Dr. Novotny can talk better than I can about that, but we do use better modalities looking for whether a child or an adult is a seizure candidate, as a epilepsy surgery candidate, because we can see differences in the way neurons take up glucose, and we can mark that, and we can say that this part of the brain is hypometabolic and this part of the brain is hypermetabolic, and then we can decide, along with the EEG studies, whether or not a patient is a candidate for epilepsy surgery. But the fine-tuning, looking at the receptor level, genetics, looking at the genetic changes that could change the way a drug can interact, I think is part of the whole idea of precision medicine. Let me give you an example. So there's a patient out there who had terrible, terrible epilepsy, and fortunately this patient had access to really good genetic testing, and we found an NMDA receptor that was mutated but on an off-site. Well, there was already a drug that conformationally should bind to that region differently than what was thought. So we thought that was a candidate drug for this little girl. And it was actually trialed, and the girl had a significantly decrease in her seizure activity based on computer modeling and knowing the genetics of the receptor. I mean, that's, if we had a hope, that's what it would be, but clearly we're not there yet. But that just lets you know that this whole idea of precision medicine, coupling genetics with computer design algorithms for proper drugs that can bind the particular receptor, I mean, that would be wonderful in our field. And we'd all welcome that, believe me.
Because right now, I'd imagine that for us and for those of you who have been through epilepsy treatment, it feels a little bit like trial and error.
Yeah.
Right? I think there's this hope that once we get the diagnosis, that will specify the treatment. And for some epilepsies, that's true. But unfortunately, that's for a real minority of the epilepsies that we deal with. We have big pots of drugs we think might work for this kind of epilepsy, but there's not a diagnosis associated with a particular drug usually, although there certainly are exceptions. So we would love to be where you're pointing us towards.
Can you hear me?
Yeah.
All right. So first I wanted to add one additional comment to the gentleman asking about work and driving. If you're able to be in a location where public transportation is helpful, I actually take the bus to work every day, and regardless of whether I'm allowed to be driving or not at the time, my coworkers just know that I always take the bus. And so there's never any assumption, so it allows you maybe to have a conversation with, one person or a limited group of people, and then, your behavior is just you take the bus, and that's just the expectation. So, it allows you to choose whether you want to have that conversation or not, and, maybe gradually over time. Obviously, public transportation only covers a certain amount, but, some cities, especially if you have a coverage area like Boston or Washington, D.C., where there's, if you're able to have that flexibility and getting a territory that's more friendly with public transportation, then that might be an additional avenue to consider. So, and then my question, there's been a lot of research on valproic acid and birth defects in pregnancies and things like that. What about, if you're taking valproic acid and then you switch? How long does it need to be out of your system? Are there additional studies, there's always still a risk, or it decreases over time? How does that work?
That's a great question. I'm not aware of any particular studies, but we could make an assumption based on how we know that effect on pregnancy seems to happen, that there should not be a long-term effect, right? So once that drug's out of your system, which really wouldn't take longer than, say, a month of not taking it, if you then became pregnant, the effect of valproic acid would essentially be gone at that point. I think that's fair.
Yeah, that's fair.
Obviously, if you are already pregnant,
Yeah.
right? And I'm not saying you, I'm saying in general, right? Anyone in the universe, if you are already pregnant, unfortunately.
Females, though, right?
Females who are pregnant, right? Thank you. He's the smart one. So, yeah, the problem is that by the time you know you're pregnant, then a lot of the things that valproic acid would affect have already formed, unfortunately. That's one of the challenges, I think, of this area. It's a great question.
Hi. Years ago, I read that a high-fat diet used to be used to control epilepsy before we got the fancy drugs. I was wondering, is that true, and how does it work?
The answer to that is yes, we still use it. We use it a lot. We have a very high proportion of patients who are intractable who are on the ketogenic diet and a lesser fat diet called the modified Atkins diet, who are very well controlled.
Mm-hmm.
So it's still around, we still use it, and we still don't know how it works.
All right, I've got another question from our webcast for Dr. Saneto. 4,000 patients have come to Oregon, and data has indicated that microdosing of THC is actually what works under the psychoactive level. Are you aware of this information, and if not, would be biased in presenting information related to THC research coming out of MX Biotech in Eugene, Oregon?
No, but when the FDA decided that their cutoff for THC-free compounds was 0.3%, they based that on Petri dish binding of THC to the CB1 receptor. So that's what they claim that's undetectable in bioassays. So that should mean that you have pure CBD. Nobody quite knows how much THC you need because THC binds so avidly to the CB1 receptor. And the breakdown mechanisms aren't known. And some of the, at least the two large studies that I showed you about people who smoked, which is likely high in THC, didn't seem to have a benefit. And these people had no bias one way or another whether it worked or not, because as you saw, most of them were still smoking it. So it just didn't stop their seizures. And so, you know, maybe it might be helpful. We just don't know. You have to kind of think about why would pharma risk studying something that they thought might not work. They wouldn't. And so why are companies trying to enter the field looking at just CBD versus tinctures of THC? That's another question, because most of the time pharma companies are not driven by ethical consideration of the betterment of mankind. They're interested in the green stuff. And so they go where the money is. And if
the other green stuff.
Right.
Yeah.
Yeah. And if they really thought that THC was going to be beneficial, then you would think it would have popped up. But, you know, anything's possible, and, you know, you have to explore it. In the animal models, THC is helpful in some of the animal models. So, you know, if there's going to be a subpopulation maybe that will benefit. We just don't know because it hasn't been well studied.
I'm wondering whether it's possible to purposefully trigger seizures. And secondarily, when you're doing care plans for kids, do you have any concern on how far they are from an emergency room? You know, you call 911 after 5 minutes, and then do you have any consideration that they're 15 minutes away from a hospital versus 25 minutes away from a hospital?
Yeah, absolutely. So for your first question, there is such thing as a reflex seizure, a seizure that can be provoked by overbreathing. And those of you who've had an EEG know that we make you do that deep breathing thing, which is to try and provoke sometimes a seizure, particular kinds of seizures. Doesn't happen for everybody with epilepsy. There are kids we were just talking about who can provoke a seizure by making flashing lights in front of their eyes, and some kids actually enjoy that and enjoy freaking their parents out by doing that. Kids will be kids, man. So the answer to your question is yes, that can happen. Just to be clear, for the vast majority of patients with epilepsy, that's not the case, right? in answer to your second question, since we take care of patients sometimes in the wilds of Alaska, we do take that very much into account. Sometimes it's not just 25 minutes, to emergency response times, it's hours or an overnight flight that you can't make in the snowy season. So we have to take that into account if we're doing our job right.
Hello. We have a 6-year-old student that we work with, and we are concerned about his quality of life when it comes to restricting certain things he might not be able to do, or we don't think he should be doing, like climbing on monkey bars in really high places or running around on blacktop. Do you have any, or concrete stairs he has to go up for another class? Is there accommodations we should be making for that, or suggestions?
So I would start with oh, good.
Having up to 10 to 12 seizures throughout the day.
Yeah, so so drop seizures?
Absent seizures, what we think might be complex partial, or the drop seizures we've seen 2 of.
Yeah, I would start just by saying that our goal is always to allow a child with epilepsy to do everything conceivably that they possibly can. And kids amazingly survive childhood, and kids without epilepsy fall and all the time. I have a 17-month-old, and oh my God, I'm glad she's made of cartilage, because she's just bouncing off of everything. Not to make light at all of this child's situation. So I think we want to be judicious in the things that we restrict children from doing, right? There are some things, clearly climbing 2 stories up in the monkey bars, probably not a good idea in a kid who's having 10 to 12 seizures a day. Going up concrete stairs, obviously a challenge. Maybe there's somebody who can accompany them, that sort of thing, making reasonable accommodations. But to every extent possible, we want them to do whatever a child would normally do and not stigmatize them, and help people understand that this doesn't mean that they're different or, that they should be pejoratized. So that's a great question. I think it's something we struggle with a lot.
Hi. This is going to probably touch a little bit on the reflex seizure that you just mentioned. I've had seizures for 10 years, and typically 1 to 2 a year, so not very often. Since January, I've had about 5 or 6, and the last 4 have had to do with things falling, in particular shelves. As I'm moving, a shelf falls, and I go into one. And is that something, I don't know, advice, suggestions? Is this something, rational or irrational? I've now gained a fear of shelves and things falling.
Yeah. Like I would too.
I would, exactly.
Right?
Yeah.
Is there, is medicine, I'm on medicine, clearly I have been for the last 10 years. How do I go about this? Or how would somebody go about this?
Yeah, and I would just say that I think it's a common phenomenon that people can develop fears around places where their seizures happen or circumstances in which their seizures seem to occur. And that can be really life-altering for patients with epilepsy, and that can be a real challenge. So,
so there are, let me give you an example. So when I was a fellow, there was a guy who was a songwriter, and he had a seizure every time that he heard Billy Joel's Piano Man. And he would have a seizure right with a piano riff, and he could tell you. And we all kind of said, yeah, right. Well, we brought him into the unit, and sure enough, he had a seizure. And so we say, we know where it is because we captured one of your events. Surgically, it's in a real strange spot that's not eloquent. We could take it out. It looks like it may be a little cortical dysplasia there. He goes, no, I just turn off the radio when I hear Billy Joel, and I don't have any Billy Joel albums in my house. Now, so that was one way. There's something called reading seizures, where certain cadences can trigger something, and you train the child just to read in a different cadence, and that seems to be helpful. So there are workarounds. I'm not so sure about the shelf issue, though. But
yeah, I was going to say, is this something that's like a sound that's getting me, or is it because I'm, it falls, you react to go catch it?
Could be, because you could have a startle-like reflex that triggers an event.
Right.
And that's really a possibility. Mm-hmm. You could actually take a shelf into a monitoring unit and drop it and see if you capture something.
I'm wondering if you believe that the failure of a lot of these medications in working has a lot to do with the failure of generic medical treatment. So generic medicine as it is practiced, i.e. that most people with the symptom of a seizure are thrown very quickly into a generic box, i.e. you have epilepsy. Even though in every single one of those patients, the contributing factors to creating that symptom are very different. But instead of looking at the very specific contributing factors that are creating the symptom of a seizure, we just throw them into a generic box and say, everybody in this box takes this medication. Is that good medicine?
So I'll take a crack at that, and then I'll back slowly away from the microphone. So I guess what I'd point out is that actually, when you look at patients with epilepsy, about 2/3 of patients end up becoming seizure-free on one of the conventional medicines we use. And that doesn't make many headlines, but that seems to be the case when you look at large populations. The challenge, and you're rightly raising it, is with that third of patients who, of course, don't become seizure-free, right? And you're absolutely right that there are innumerable factors that play into that patient's seizure. No one patient is exactly the same. And I, just speaking for myself, am in no way smart enough to understand those factors. We do know some factors that we generally take into account. Simple things like, are they allergic to a class of medications? What kind of seizures do they have? There's certain kind of medicines that would make certain kind of seizures worse. So there are certainly, and this is a question, getting back to a question we talked about earlier, there certainly are things that we always take into account. But you're absolutely right that there are factors which play into different people's seizures that we either don't know or can't, at this level of our knowledge and understanding, take into account. I think the reasons why that third of patients, roughly, continue to have seizures is numerous. There's a lot of reasons why patients may continue to have seizures. And we don't fully understand the biology of it.
Even the ones that you are able to treat, the seizure goes away. You haven't eliminated the causes of the seizure.
Fair enough.
So have you actually treated the patient?
Fair enough. So I guess I would say that we really should call our medicines anticonvulsants and not anti-epileptics. They don't get rid of the epilepsy. That's a very fair point. It's not always that we can get rid of the underlying cause. Surgery would be one example where we can, and I am not a surgeon, as you can tell by my hands, right? So you're absolutely right. We oftentimes can't get rid of the cause. Now, I guess you could argue that's sort of similar to other things like diabetes.
I mean, is that the problem across the board with chronic illness in this country? Is that we're not treating the disease, we're treating the symptom.
Yeah, I think that's fair for a lot of conditions, high blood pressure, diabetes, and so on.
But there are some times that we treat the condition. So genetically, there's a type of epilepsy called GLUT1 deficiency. It's because a glucose transporter in the blood-brain barrier is abnormal. So we just bypass that. We use ketones to get in the brain, and we've circumvented the problem. We've corrected essentially the problem. And there's a new drug that we're trialing called triheptatonin, which does the same thing instead of the ketogenic diet. So we don't have a lot of tools to correct the underlying problem, but in some of the problems we do. And that's not correcting the problem, but it's making the problem not causing the symptom of epilepsy. So there are some. But in order to correct the etiology, we would have to do things like genetic engineering, which is something that we actually can do. So if you have a particular mutation in the cystic fibrosis gene, there's a drug that skips that mutation and lets the protein be synthesized completely. Well, those kids 5% of those kids who have that mutation that causes a stop codon, we give this drug, it skips right past and they're cured. We've corrected the etiology of the problem. So not all medicine is just based on symptomatic care. Hopefully one day we'll be more involved in getting answers to how to treat the underlying genetic condition, but we're just not quite there yet.
Hi, so I have two questions from our webcast. The first one is for Peggy. A lot of people fear being discriminated against and don't tell their friends about their seizures. The same thing happens for people at work. Would you have any advice for them, such as resources?
I think the National Epilepsy Foundation is helpful, and there's also some options for online support groups and where you can meet other people with epilepsy who are dealing with the same condition, and maybe a little bit further down the road that could be of some help.
Thank you. And the second question, someone wrote, my primary diagnosis is lupus, and its impact on my central nervous system has caused me to have seizures and be classified as having epilepsy as well. So I'm currently on medicines for both lupus and epilepsy, the one for epilepsy being Keppra. I'm curious whether this is a common scenario and if anyone on the panel has patients like this or have seen studies on this.
I think we all have a few patients who have lupus. Unfortunately, patients with lupus can have cerebral manifestations like that. The damage to the brain can cause seizures as a manifestation. I'm not aware of any particular studies about patients with lupus as a cause of their epilepsy indicating a particular treatment being better than any other. I'm trying to find where the webcam is so I can speak to you. So I'm not aware of any.
Yeah, I'm not either.
Winding down on time right now, so we've got one last question, and then I think we'll probably break for lunch.
As a school nurse, we're seeing more and more students with seizures coming to school with their prescription for midazolam. There's not many school districts that I am aware of where the nurse is there for the whole school day. So it requires us to delegate, if we choose, to have someone who's not licensed give them midazolam. So there's a lot of conversation among school nurses, is this a safe practice for us? Does it require a nurse's assessment before and after administering the midazolam?
You want to start? I'll chime in.
All right, I'll start out. So I guess what I would say is that if you think about who gives the majority of intranasal midazolam, it's parents. And I absolutely think that people who are not licensed medical professionals can be trained to do it safely.
Yeah, look at us.
I actually just stayed at a Holiday Inn Express last night, right? Exactly. Do I look like a doctor? Oh my God. So I think that can happen. You're right. It's a challenge. It's a system-based challenge in the school. Who's going to do it? Who's safe to do it? Every child seizure is different. At what point do we decide that little Billy really now has gone on long enough? Not every seizure is a convulsive seizure. So it is a challenge, and it's something that we need to work together to try and address. Because you're right, most schools do not have the luxury, of having a nurse there all the time. Absolutely right.
Okay, we'll take one last question over here. Okay.
I had one thing I wanted to say. In looking up resources, I found one that, with all my experience as an epilepsy social worker, I didn't know. So I'm educating you all in case it ever comes up. So a lot of times a disabled adult child is on SSI because they haven't worked. But if they are adults older than age 18 with the epilepsy starting before they were age 22, if their parent is deceased or starts receiving either disability or retirement Social Security benefits, then that child can get their Social Security disability claim on their parents' earnings record. So this could be a child that was never able to work, and I would have thought, well, all that person can get is SSI, but there's a way to get it on your parents' earnings. So anyway, I never heard that, and so it's worth keeping stored in the back of your mind.
Okay, thank you to the panel.